segue between evidence-based medicine and medicine-based evidence, so I think it's probably apropos to follow with this. I have 8 minutes. I could present why the algorithm exists and how to interpret them, or the details. I think the former is more important at this point, so that's what I'm going to focus on. In the early editions of the guidelines, we provided an algorithm. It was extremely popular, the most popular part of the guidelines. But to be honest, it wasn't evidence-based. And so in the subsequent editions, it disappeared because it wasn't evidence-based. It didn't belong in an evidence report. And the overall audience response was, what happened to the guidelines? Nobody was particularly happy with this. We recently published the 4th edition of the guidelines, the most scientifically valid edition yet, and the audience response again was uncertain. These were not exactly what people expected. They weren't particularly clinically useful. People couldn't take the guidelines to the bedside and figure out what to do next with their given patient. Basically, people wanted an algorithm which wasn't evidence-based, which was a bit of a sticky wicket. There was extremely little evidence on algorithms, not enough to create an evidence-based protocol. So a new algorithm will have to be based on clinical experience. Now we know that anecdote is the lowest level of evidence, class whatever, depending on how many levels you have. So how do you make an algorithm out of anecdote? Well, the multiple of anecdote is probably something akin to wisdom, perhaps. And can we bring that wisdom into something that's meaningful for us? And we tried to do that with a consensus-based algorithm. Selecting participants is obviously crucial. We need long-term clinical experience in each individual participant so that they have gone through the anecdote many, many times. There have to be still an active practice so that their recommendations and thoughts are current. We need all involved disciplines because neurotrauma is a multidisciplinary sport. And we need geographical representation because clearly things are done differently in Europe and the US and the Far East, etc. So we need to be applicable around the world. What is the consensus process? Well, basically you take the group that you have assembled and you take an individual treatment question. Now that has probably been iterated numerous times. We did this for over a year before we got started to try to get things up and running. And then you run it through this group in a formal discussion session, and then you have a blinded voting. And then you have to set a criteria. We set 80% agreement of a cohort of the group. If you don't meet that, you can iterate that. And you can do that 1 or 2 times more, at which point, if it doesn't come to agreement, you table it, although once in a while it gets brought up again later and reworded. If it does reach the 80% agreement, you have consensus and you can form that as a recommendation. Now, consensus-based statements are clearly not binding. They're more like recommendations. What do we do when we have something with which we're not comfortable? Well, we might go to a local expert or someone who has more experience in it and get a curbstone consult. What basically these are is curbstone consults with about 42 internationally known experts. It's a suggestion of what they might do in a similar situation. They do represent evidence, the lowest form of evidence, but it's a pretty strong process when you go through a Delphi-based consensus process. So we finally came to the meeting after well over a year of work in advance to this in April of 2019. The scope of this process was a suggestion for a safe and modern means of TBI care aimed at help non-experts, although valid probably to everyone. What it is not is the best care or standard of care, the right or the only way, always the best approach, legally binding, a basis for measuring care, so it's not a QI document, the way that any one of the experts who put it together would manage a patient, or a substitute for thoughtful care and clinical judgment. We started with Tier 0. Tier 0 is basically the cost of doing business when you admitted a patient with a monitor in their head to ICU. There are expected treatments, and then there are a couple of recommended treatments. We also had a list of treatments not used. Now this does not mean that you are wrong to use these. They were recommended not to be routinely used in the care of severe traumatic brain injury patients. The format that we used for the algorithm was 3 tiers. And these were based on risk-benefit ratio, where Tier 1 was the least risk. And so it's expected that, when possible, the lowest tier treatments will be used. The approach is bounded by 3 principles. There's no rank order within a tier. There are numerous treatments within a tier, and although they may be ordered within the box, there's no difference between them within a tier. It is not necessary to use all the modalities in a lower tier before moving to the next tier. And if considered advantageous, TEERS can be skipped, such as doing a decompressive craniectomy on a diffuse injury 4 patient. So in the ICP only protocol, the first protocol, there's obviously one set of 3 tiers of treatments. We also stress neuroworsening. Neuroworsening is not just refractory intracranial hypertension. Neuroworsening is acute worsening of the patient, which is well defined by such as decrease in the Glasgow motor score, change in pupil reactivity or size, new focal motor deficit, or the herniation syndrome. This is something that requires emergent evaluation to determine what it is and treatment to reverse it. So that's a separate aspect from simple ICP refractories. And then finally, when do you take a monitor out? This is an incredibly contentious issue. And in all the trials we've done to date, we've not been able to settle this very well. So what we did was, rather than try to come up with absolute numbers, we tried to concatenate all the people's opinions into a heat map using a traffic light scenario, where green is go, red is stop, and yellow is in between. What we did, we took patients who had never had intracranial hypertension. When do you take the monitor out? Those are patients who have had but only required tier 1 treatment. And then we have patients who required tier 2 or tier 3 treatment, but now don't have intracranial hypertension. So these are 3 different scenarios based on the CT, the Glasgow motor score, and the pupillary response, and the time after time that their ICP has been normal. And as you can see, where red is accented, the willingness of people to leave a monitoring goes up as the severity of injury increases. So the idea is that give some idea of what other people might do in this situation, because prolonged monitoring means prolonged treatment and possible toxicity. Now the combined algorithm will be the next one to come out. This is obviously a 2x2 matrix because we have ICP and brain tissue oxygen. Type A is both normal, no treatment. Type B will be ICP elevated, brain tissue oxygen normal. That will have a 3-tier algorithm. Brain tissue oxygen abnormal and ICP normal will have its own separate 3-tiered algorithm, and the same for when both are abnormal. That will be the combined protocol, which is really a step into targeted therapy. So the details of this, well, fortunately I can say that published ahead of print, the ICP only should come out in intensive care medicine within the week. So we'll have the details of this, and then I'm sure a lot more discussion will be warranted. As far as the ICP and brain tissue oxygen, that will hopefully be out by the end of the year. We're still working on it, not 100% sure where it's going to go. This is open access, so everything, including the supplementary material, is open access and free for everybody. Thank you very much.